Hi and welcome to Andy and Medical Mission. Welcome to the series Beyond 2020, the series where we look at blindness prevention strategies in countries with developing eye care services. Today I want to talk about 5 tips that will help you when you're screening patients to find the patients that are at most need and to help yourself to pick up pathology in a very simple and easy way. Tip number 1 is don't just pick patients based on their visual acuity. Of course, you're trying to find the people with the worst vision, so perception of light, hand movement, counting fingers type vision. Of course, you're going to want to operate on those people before you want to operate on anyone with slightly better vision than that. But I would urge you to bear in mind as well other pathologies which are blinding. So things like pseudoexfoliation glaucoma, which we find a lot of in the Beni, in the northern Bolivia where we work, will blind patients. If you have a lens that maybe the patient can see through, but it's very, very big, it's very wide, hyper mature, and it is closing the angle of that eye, then again, that is a lens that maybe you want to take out. Certainly with pseudoexfoliation, if you remove the lens, well, you remove the problem to a large degree. So consider as well other pathologies that maybe at the moment today visual acuity might be 640, 8 or 660, but in a year's time that person might be NPL, no perception of light. So that would be tip number 1. Don't just pick based on the worst visual acuity. But I understand if you have hundreds and thousands of people turning up, it's a very easy thing to do, isn't it? Just give out tickets to the people that are bilaterally blind first and then see how many spaces you've got left. And I understand that. The second tip that I want to talk about is have a look before you dilate. Again, if you are in a pressure situation, you've got 100 surgical slots, you've got 1,000 patients that have turned up, most of them with very poor vision, it would be very simple to just say to a colleague or nurse in the clinic, okay, let's just dilate everybody and see what we've got. But if you do that, and it would save time to do that, but you're going to miss a lot of clues based on the iris itself. So rubiosis you will miss if you dilate everybody. You're going to miss it as a diagnosis. You're also potentially going to miss pseudoexfoliation glaucoma as well. And we have just come back from a trip in northern Bolivia where we have seen hundreds of patients with pseudoexfoliation. And you will see this on the pupil margin, but once you dilate that eye, those little cells, those little proteins that are stuck to the iris, to the pupil, they're going to disappear and you're going to miss them. So again, have a look. Angle closure is another one. If you, or a synechia, you're going to miss it if you just dilate everybody. My third tip relates to taking visual acuities. Again, if you have everybody whose perception of light and hand movements, well, okay, that's your visual acuity. You may not be able to take that any further. Doing a visual acuity with a pinhole will give you a lot of information. And sometimes we rush this when you have lots and lots of patients and maybe they can see 612, 624 and you think, yeah, that's good enough. It's still worth pinholing because in the event that someone can see 624 and you give them a pinhole to look through and okay, great, so their vision improves from that, then okay, they just need glasses potentially. But if their vision gets worse, then you know that their central vision is affected and you're probably going to find in that patient something happening in the macula. So it's a really simple way to give you a clue as to where to look for once you've dilated that patient. So patients that vision gets worse with pinhole, you're looking at the macula, and it's worth doing it. It doesn't take that much longer to add that step into your screening, to do a visual acuity, and then to, unless they have perfect vision, then to do a pinhole as well. And it'll give you some information that may well steer you down the right path. The only way you're going to be able to tell depth in an eye is to get a binocular view. And so if you have macular edema, if you have swelling of the discs, you're going to get a much better view if you dilate. And again, it all takes time, and of course it depends how much time you actually have. But if you are trying to give a reasonably complete ophthalmology service and not just screening for surgical patients, then dilate everybody. You'll pick up a lot more pathology. You're going to have a much better view because you're going to be able to judge depth because you've got a three-dimensional view. My final tip is, I imagine if you're going around screening for patients, you're going to bring with you a certain amount of medicines. We always do. We collect donations and we collect medical samples, and these are really useful in remote settings. You find pathology that doesn't need surgery but needs treatment, then you can give out samples, and hopefully your patients will do well on them. And we've been doing this for years, but of late we've found a real benefit in also being able to bring along medicines that you can inject. So it doesn't take a lot of space. Bring some dexamethasone with you. So bring some 1 ml, some 3 ml syringes and some needles to draw up from, and you'll find that you can get a really good response. So we've had a couple this week where people have come in with really inflamed episcleritis, and giving them a course of drops probably wouldn't have had that great an effect. The drop in the eye is there for a moment, and then mostly it's washed away by your tears. But if you were to put, a good 0.5 or 0.6 ml of dexamethasone underneath the conjunctiva, well, that's going to sit there for a number of days until it's fully absorbed, and that will have a much better impact in these remote communities. So bring your medicines, bring your samples, give them out where appropriate, but also don't forget that it doesn't take a lot of space just to bring a few injectables as well. And these can have a real impact for your patients. So that's it. Those are my 5 tips. Just in summary, 5 simple tips. Don't just select patients based on their visual acuity. Consider also diseases that will blind your patient where their vision is not that reduced right now. Things like rubeosis, things like pseudoexfoliation glaucoma. Dilate all of your patients, but look before you dilate. You'll pick up a lot by doing it that way round. Pinhole your patients when you're doing your visual acuity. You'll pick up additional pathology, and finally make sure that as well as all the medicines that you're going to leave in drop format, have some that are injectable, because you're going to have a much bigger impact earlier with that strategy. So that's it. I hope you've enjoyed this. I hope you found it useful, and I'd love to have your ideas and comments when you're screening patients in the area that you work in. How do you do this, and what are the tips that you'd like to share? Thanks very much. I'll see you on the next one.